Hello everyone, my name is Christine Jose and my team will be presenting our analysis of HRSA clinics tobacco screening rates in 2019. This analysis and presentation was prepared by Carl Butler, our data analyst, Gaston Equi, our technical writer, myself, Christine Jose, our project manager, and Magdalene Kuznia, our subject matter expert. We prepared this analysis for our healthcare analytics course at the University of San Diego, and our professor is Dr. Barbara Berkovich. Background. HRSA, which stands for Health Resources and Services Administration, is the primary federal agency of the U.S. Department of Health and Human Services. One of the national quality measures reported by HRSA is the tobacco use screening and cessation intervention rates. This is a very important quality measure because tobacco use can cause various diseases such as cardiovascular disease like hypertension, lung diseases, stroke, and cancer. And tobacco use is the #1 preventable cause of death. Per the CDC, in 2019, 34 million U.S. adults smoked cigarettes, and 58 million non-smoking Americans were exposed to secondhand smoke. So with the high prevalence of tobacco use and exposure to tobacco use screening rates is definitely an important quality measure in healthcare. This is an overview of our project timeline. Our group met at least once a week for 7 weeks to complete this project. Introduction. So overall, we found that HRSA is already doing pretty well with tobacco use screening. What differentiates the HRSA population with other national cohorts is that HRSA provides funding for different clinics across the U.S. and its territories to improve the healthcare in populations that are geographically isolated or medically or economically vulnerable. To explain what the tobacco screening rates are, basically in HRSA clinics, providers should be screening every adult patient as to whether or not they use tobacco. And if they do use tobacco, they should receive cessation intervention. So these rates are the percentage of patients being screened for tobacco use, and they are not the percentage of patients that actually use tobacco. Moving on, we found in the literature that tobacco use screening and cessation counseling is one of the most cost-effective clinical preventive services. So it's great that HRSA is already doing a good job at tobacco use screening. Our team's aim is to provide HRSA with recommendations to further improve their screening rates by identifying differences in adult tobacco screening rates across HRSA clinics in the U.S. and its territories.
In terms of the methods, for this project, data were derived from HSRA 2019 National Award that measured tobacco screening rate, cessation, and hypertension rates. For the variables, we use adult patients from 18 to 65 years old and from 65 years old and above. In terms of the tools, we used Microsoft Excel and Tableau. We performed some aggregated state rate calculations, such as aggregated screening rate for each state versus clinic, aggregated screening rate for hypertension, hypertension count, controlled and uncontrolled.
Okay, here we're going to get into the data visualizations that we've come up with as a team. Our aggregated screen rates, which is going to be consistent throughout these next 3 visualizations, with red being the lowest, green being the highest screening rates. And as you can see, the average screening rates are between the 80-90%, with some being higher. But the 3 that are kind of concerning are Nevada, Wyoming, and Oklahoma, which are all below that 80% threshold there. So as you see, probably those 3 states probably need some help or guidance on how to bump up those numbers, maybe from the higher screening rate states. Here we have our tobacco screening rates versus hypertension. This is something that we just wanted to kind of look at to see if there's any correlation between the two. Obviously, you can see, right, with different screening rates from red to yellow to green, green being high, those hypertension rates, the sizes of those dots are pretty consistent throughout all the healthcare centers throughout the United States for HRSA centers. So obviously that tells us that there is really no correlation between the screening rates, tobacco screening rates, and hypertension rates. But it was just a good data point to try to see, if there's any correlation between the two, if it provide us any more data. And then lastly, here you have our tobacco screening rates versus total cost per patient. As you see here, same thing as before, right? Your red dots are your low screen rates, green colors is your high screen rates, and then the size of those actual dots is how much the cost was per patient. And as you can see here with the green, like New Jersey, New Mexico, they had very high screening rates, but was very low cost to the patient, where you even had maybe lower screening rates, which were high cost to the patient. So that tells us that no matter what happens, if we bump up the screening rates, that has no effect on the cost to the patients or even the practice. So what do the three data visualizations tell us? Right, it tells us that the average of HRSA healthcare centers screening for tobacco cessation ranges between 80 and 90%. The screening rate, whether high or low, does not have a major impact on hypertension rates throughout all HRSA centers. And then lastly, high screening rates have a lower cost than those with lower screening rates, indicating that increase of screening would not affect cost towards the patient.
Hi, I'm Magdalene Kuznia, and I'll be leading the discussion and call to action portion of this presentation. So first, we'd like to point out that our data does not show how many individuals across the United States and territories who actually use tobacco. We are only looking at the people who are getting screened for tobacco use. So this does not give us any comparison to use and screening. It's just looking at screening rates. Secondly, our literature search shows that certain medications are off-label use products for tobacco cessation, so such as Wellbutrin. Wellbutrin is an antidepressant, and this can show us that sometimes our patients are getting screened for depression and maybe not smoking cessation, or the reverse. But either way, there's a possibility that some screening may be going under the radar. Additionally, there's an uptick of high school students who are using tobacco now, and this could be due to e-cigarettes or something else. But the U.S. Preventive Services Task Force in 2020 came out with evidence saying that high school students from 2011 to 2019 started at a 1.5 tobacco use rate to now a 27.5% use rate, ending in 2019. This leads us to our call to action. So first, it's important for us to standardize tobacco screening across the United States and territories. The CDC recommends using the 5 A's. So first, we would like to ask about current tobacco use, advise to quit, and see if our patient is ready to quit. So assess if they are ready to make a quit attempt. If they're not ready to quit at this time, that's okay. We'll just leave the door open for future discussions. But if they are ready to quit, we can help them by providing brief counseling, some medication if that's appropriate for them, or additional services such as making sure that their insurance covers the medication or sending them to support groups. But we want to be there to support them. Another form of support is to finally arrange a follow-up appointment. This can be in person, virtually, or by phone. Additionally, we would like to update the training for the providers on the HRSA website. So we noticed that the HRSA website has a ton of resources for our providers, and we thought that by adding in tobacco cessation resources for providers, such as the 5 A's chart in our previous slide, may be really helpful for providers. And then lastly, our call to action states that we would like data for tobacco screening cessation and interventions for patients under 18, because although there cannot be studies done on tobacco cessation interventions for people underneath 18 years of age, it's never too early to start assessment, and it's never too early to start education. There's a possibility that we could be missing out on a prevalent group
for tobacco use. And by looking at their screening rates, it allows us to detect early. And then lastly, a shout out to the Northeast. They've done a great job providing tobacco screening for patients. And we'd like to see how they're doing it, whether they're reaching out in person or on the phone, or if they have a patient portal. But if we could understand their method, then maybe we can apply it to the rest of the United States and territories.
We want to thank HRSA for providing extra funding and education to support clinics and providers throughout the United States and its territories. We also want to thank HRSA for allowing us to provide our recommendations to help inform care. Slide 15 and 16 shows our references where we collected data for this project. Basically from the Agency for Healthcare Research and Quality, from the Center for Disease Control and Prevention, from Health Resources and Services Administration, and also from the U.S. Preventive Services Task Force. At this moment, we will welcome any questions, any concerns in relation to this presentation. Thank you.